Alrighty, everybody, hello and welcome. We're going to get started in about 2 minutes. I see folks trickling in. We'll give everyone a second to get settled. Alrighty, hello to the folks that just joined us. We're going to give everyone 1 more minute to join, and then we'll get started. Alrighty, everybody. Good morning, good afternoon, and good evening. It's the top of the hour, and I know that we have a lot to talk about here today, so we're going to go ahead and get started. I'm very excited to see you all here today. Thank you for joining us for Actionable Solutions toward National Patient Safety Oversight. My name is Olivia Lounsbury. I am currently serving as a member of Patients for Patient Safety, a wonderful organization focused on what patients' family members can do to advance patient safety. I'm also working as the Quality and Safety Program Coordinator for the Johns Hopkins Children's Center, Human Factors Research Assistant at Oxford University, and pursuing my master's in Georgetown in clinical quality and safety. My impetus for involvement in this work is my own experience with AML leukemia, so I'm very excited to talk about how patients themselves can really advance what we're doing with patient safety in this space. I'm very excited to be joined by a number of really experts in this space from around the world. So thank you to folks who are joining us at 8 p.m. at night over there and in some other areas. So thank you for being here. I'm joined today by Marty Hatley. Marty is joining us from Chicago, Illinois. He is president and CEO for Project Patient Care, a Chicago-based safety and quality improvement coalition dedicated toward using the voice of the patient to improve care. He also serves as co-director of the MedStar Institute for Quality and Safety, which integrates open and honest communication strategies, patient and family engagement, research, and high reliability organizational methods into quality and safety improvement work. He is passionate about advancing the roles of patients and family members play in improving safety as healthcare advisors and co-creators of solutions. He's been active in the space for over 25 years in healthcare system transformation work on projects funded by Centers for Medicare and Medicaid, CMS, the Agency for Healthcare Research and Quality, AHRQ, and Patient-Centered Outcomes Research Institute, or PCORI, among many others. Hatley is a founding member of Patients for Patient Safety US, the World Health Organization's consumer-led network of patient safety advocates in the United States. Marty, welcome, and thank you so much for being here.
My pleasure to be here. Olivia. Armando, I'm getting a request for the passcode. Can you give it to me? Oh, I'm sorry. I think the person who's requesting it got it, so we're good. Olivia, sorry to interrupt. I'm just trying to help people along, but back to you.
No, good. That's an exceptional role of co-facilitator. So thanks for being here.
Yeah.
All righty, I'll move on next to Rosie Benneyworth. Rosie joined the Healthcare Safety Investigation Branch, HSIB, in August of 2022 as the interim chief investigator. She has a longstanding interest in improving quality and safety of care that people receive. Rosie joined us from the Care Quality Commission, or CQC, where she was Chief Inspector of Primary Medical Services and Integrated Care, with responsibility for regulation of a portfolio of services across many community sectors, introducing the regulation of integrated care systems, and leading thematic work such as the review into do not attempt CPR decisions during COVID-19 pandemic. I'm sure that must have been a very large feat, so thank you for doing that, Rosie. Rosie was a GP in Somerset for 15 years, and during that time, she also worked as clinical commissioner with Somerset Primary Care Trust and Clinical Commissioning Group, commissioning a wide spectrum of services across the county. She was also the managing director of the Southwest Academic Health Science Network, AHSN. She was also the deputy chair of the National AHSN Network and led the patient safety collaborative work during that time. She was a non-executive director and vice chair of the National Institute for Health and Care Excellence, abbreviated as NICE, between 2016 and 2019, and is currently a trustee of the Nuffield Trust and National Children's Orchestras of Great Britain. Rosie, thank you so much for being here.
Oh, it's lovely to be here. Thank you very much for inviting me.
Excellent. All righty, I'll move on next to Hanna. Hanna joined the Safety Investigation Authority Finland as the Chief Safety Investigator of Social and Healthcare in June of 2021. She was responsible for leading and developing social and healthcare investigation. Hanna earned her PhD in health science from the University of Oulu in 2014. She holds the title of Associate Professor in the field of Health and Wellbeing Services in the system at the University of Lapland. She acts as a professor of practice at the University of Turku in the field of social and healthcare safety. She has over 80 publications related to social and healthcare systems. Her research activities aim at increasing the understanding of health and social care system quality, effectiveness, safety, and integration. In addition, she is a trained occupational therapist and qualified teacher. And prior to starting at her current job, she acted as the senior specialist at the Finnish Institute for Health and Welfare in issues of patient and client safety, quality registers, and service packages and chains in health and social care. That was a mouthful. So Hanna, thank you so much for being here and for bringing your significant expertise. We're really excited to have you.
Thank you so much, and hello for everybody from Helsinki, Finland. Nice to be here.
Excellent, thank you. And last but not least, we are joined by Sinnøve. Sinnøve is the head of relations, learning, and quality improvement at the Norwegian Healthcare Investigation Board. She has been working with the investigation board since the very beginning in 2018, and she is responsible for the development of a healthcare investigation method and process, the board's internal education program, and ensuring that the board's reports and recommendations are conveyed in a way that's useful for its recipients. Sinnøve has a political science degree from the University of Bergen. She has worked as a researcher in the Uni Research Rokan Center in Bergen and at the University of Stavanger in the field of societal safety. She has published more than 10 scientific articles in Homeland Security. And in addition, she has education and experience in improvement methodology and implementation science through the Nordic Improvement Agent Education and IHI's Improvement Coach Program. Before she started at her current job in the investigation board, she led the work of implementing the Norwegian National Patient Safety Program titled In Safe Hands 24/7 in the Western Norway Regional Health Authority. Sinnøve, thank you so much for being here. Really excited to have you.
Thank you. Thank you for organizing. Hello, everybody from Norway.
All right, excellent. So I'm very excited to have everyone here, and participants, do not be shy. Please put your comments and questions and chats and thoughts in the chat box. We will aim to answer as many of those questions as we can in live time. If not, that might be a nice impetus for us to schedule another one of these events and answer some more of those questions in detail. So please don't be shy. We would love to hear from you wherever you are in the world. So I'm really excited to start out with our first question, and I would love for each of these questions, if we could have our speakers give their insights into some feedback around these questions. So I'll start.
Olivia, before we jump in, can we cover the objectives? I think it's on our next slide.
Oh, absolutely. Thank you for the reminder there.
Yep.
Alrighty, everybody. So our objectives for this webinar include discussing the need for greater national patient safety oversight from a number of different perspectives and geographies, examining the features of and lessons learned from independent patient safety investigation bodies, and evaluating solutions for other countries seeking to emulate the existing models. And then
Olivia, if I could just do a little bit of commentary on this for our guests. I think you've covered this with our speakers, but we are in the United States really looking at your solutions in your countries, because we're trying to generate some momentum for the same kind of agency to be established here in the United States. And our advocacy is really from the patient perspective. Patients for Patient Safety is a branch of the World Health Organization's Patients for Patient Safety Network. We have Sue Sheridan among our participants today. Sue and I were involved in launching that network and growing it. And we're really intensifying that growth in the United States right now, because we've realized after 20 years of working on patient safety that patients haven't played the advocacy role that we need to play, and that we think we can play to really get the attention of our policymakers. So we have a lot of patient safety lessons learned in the last 20 years, but we still have a really uncoordinated approach in this country. So we're really excited to look at countries that are coordinating at a national level your work on patient safety. Okay, Olivia, thanks for letting me jump in with that framing. I appreciate it.
No, this is excellent. I think this definitely illustrates, colors our perspective nicely for this discussion. So thank you so much, Marty. Marty and I are going to be going back and forth a lot. So if you hear commentary, hopefully it's a good thing. So I'll start out with our first question, and maybe Sinnøve, we could put you on the spot to go first, and then others, please do jump in. But one of the challenges that we often face with any improvement initiative ever is kind of making the case for why this needs to be a priority and kind of getting that buy-in. So how do you make a case for a need for greater national, patient safety oversight in order to leverage the resources that are necessary to establish some sort of an investigation body? And kind of a part two to this, how do patients and family members help advocate for this buy-in? Sinnøve?
Yeah, thank you. I think so. We didn't actually make a case to leverage resources for establishing this investigation body in Norway. The story about our establishment is quite fascinating and unusual for establishing national bodies in Norway, at least, because it actually started as a patient and next of kin initiative, coming from families that had lost their loved ones in serious adverse events in hospitals, and these families, they worked very hard and systematically, and they managed to convince the Minister of Health that Norway needed an independent investigation body to make a really fascinating story very short. So very few actually, except from these patient and next of kin organizations and some academic institutions applauded the creation of a new national healthcare investigation board in Norway. And the opponent's argument was that we already had a board of health supervision in Norway, and they didn't quite manage to see what the role of an investigation board should be. So while the aim of the public supervision is to ensure that the services is provided in accordance with laws and regulation, and of course to sanctions if they don't, the aim of an healthcare investigation body like us is not to point out breach of duty or to report blame or liability, but to point at patient safety risks that occurs. Often in spite of the fact that laws, regulation, and procedures have been followed. But now in 2022, the winds have changed in the time that have passed, and since these patient and families member initiated this work, and we are now experiencing a lot of interest and requests for our work. So I guess the message from us in this question is that this was a really important patient initiative, and that was the engine behind the establishment of this investigation body in Norway.
Marty, it
Thank
looks
you.
like you're on mute.
I'm sorry. If I can follow up very quickly, Sinnøve, in our country, we have a lot of, the reason we asked the question about how did you make the case is in our country, we've got a lot of worry about establishing an agency like this from the hospital community especially. And so we feel like we have to make the case. Did you not have that in Norway?
Yes, well, we did have that, absolutely. One medical field actually stood out as supportive, and that was the anesthesiologists.
Same thing here.
I guess we have a long story of working with, working with safe care, checklists and all that kind of stuff. But both from the hospitals and from the governmental bodies, they didn't actually see the need for this. But it was the patient and next of kin initiative organizations that actually made this case, and they worked systematically towards the politicians in Norway.
That's fantastic.
And there was an official consultation round, and not very many applauded this, but still they managed to be a very strong force. And they work systematically towards this. So this is actually a patient initiative.
That's really encouraging for us to hear and really exciting.
Yes.
We're thinking of ourselves now less as just patient advocates and more as activists, really using our voice to get to the policymakers and ask them to do their job, frankly, and to lead on this.
And just can add one more thing. And what they actually did was to tell storytelling. That's a powerful tool. Tell their stories about their loved one and other patients and relatives.
Fantastic, thank you. Olivia, I think I'm interrupting your flow here, but I know you as well as I are eager to hear from our other speakers too on this question.
Absolutely. And, Sinnøve, thank you so much for the insights there. And thank you so much for the encouragement for the work that is being done here. Hanna, do you want to jump in next with your perspective?
Yes, of course. Thank you. Thank you so much. So in Finland, Safety Investigation Authority is established in 1996. And we have 5 branches. And the social and healthcare is the newest one. I have started 1 year ago in June 2021 as a chief safety specialist, and preparation work has done quite many years before I came to SIAF, and we are working in the same organization under the Ministry of Justice. Connected. We are not working under, but we are working connected to Ministry of Justice independently. And we have aviation, rail traffic, maritime traffic, and other accidents and exceptional events, and now social and healthcare investigation branch. And quite many years was discussion with different kind of experts, and our organization has also a very strong international collaboration with different safety investigation branches. And there was a discussion about the need to investigate independently also the cases in social and healthcare. And I must say that HSIB in England, Rosie's office was the main leader and maybe the main example how to create a social and healthcare or healthcare. We have social and healthcare in Finland, but healthcare investigation. And why we have social and social and healthcare investigation branch is because of the Finnish healthcare system, and our health and well-being system is quite integrated. So we have also social care and social services, but that's much more complicated than healthcare, I think. Anyway, And now, well, we have 18 permanent staff in our organization, and then we have a little bit over 120 experts, which are like regularly staff for us. And we have me and then a little bit over 20 social and healthcare experts, like physicians and nurses, social workers, and that's our organization. And well, I mentioned that we had a discussion with the international partners about the need to understand the incidents in social and healthcare, and how safety investigation can promote client and patient safety. Of course, with international discussion, but also with national other authorities. There is authorities for supervision, control, approve for social and healthcare, but not that kind of authority who has rights and focus to independent investigation. So there was a black hole in that area.
And how did that black hole get filled? Who stepped up and said, we need to fill that hole? Did it come from the healthcare community? Did it come from government? Did it come from patients?
It was firstly the Ministry of Justice.
Okay.
That was the first one, yeah. But then the Ministry of Health and Welfare accepted. I know there was a strong discussion, and it was not clear that it's needed, because there are also like poor social and healthcare authorities in Finland. So the question was, what is this really needed? Is it really needed that there is a new authority who comes to our field, which we know better and the best? Is it necessary that there comes from outside the box, the new actor who maybe knows better how to do investigation and how to promote client and patient safety? But that was Ministry of Justice, and then also Ministry of Health and Welfare, and then step by step, I think I do this work that I promote this safety investigation. There is still a lot of questions. Why are you doing that? Why the SIAF is coming to our field? Because it's normal. It's totally normal for maritime or railway or aviation that there is an independent investigation, but not in healthcare or social care. And I think that's the one thing that we have done, what we can do together in also in international level to promote safety investigation as a tool to promote client and patient safety.
Great, thank you, Hanna. Olivia, I'm really conscious of the fact that I'm by asking questions, we're losing time here. I'd love to hear from Rosie now, if we could, about the same question. How did you get started? What was the need, and how did you make the case if you had to?
Yeah, certainly. Well, I think we were in a political backdrop where we'd had quite a big scandal in the country. We'd had a scandal around a hospital where several hundred people had died unnecessarily due to patient harm. And I think that led to some of the kind of changes in the regulatory landscape. And certainly, I think had led to a political environment where people were much more concerned about patient safety, and it was very high on the agenda. And then a couple of years after that, in 2014, a couple of academics, Carl McRae and Charles Vincent, wrote a paper that suggested that we had an independent investigation body that looked at taking on major inquiries and safety investigations. And I think there was a recognition at the time that actually the quality of safety investigations across the NHS was quite variable, and many of them were quite poor and often didn't involve patients and people who'd been affected by harm. There was also some very kind of active patient safety campaigners who are still very active today, and I think they were feeding into the discussion. And so this very much had the political interest right from the start, and I think people have been talking about the learning from aviation and the learning from other safety critical industries for some time. So actually there was a report to the Secretary of State, and that was accepted to set us up, and we were set up in 2016, and we are at the moment hosted by NHS England. So we're hosted by the major commissioner and service commissioner across the country. A couple of years later, we were then asked to take on maternity investigations as well, because there was a growing interest in a lot of the poor maternity care that was happening. We'd had another big scandal in Morecambe Bay in the north of the country, where several babies had died unnecessarily, and that had also created a lot of interest from politicians. So there was quite a growing case for change with mid-staffs and Morecambe Bay and several of these really big scandals that were getting a lot of publicity on the back of the academic interest and academic rationale for this. So I think it was a whole host of reasons that came together. But we're now very excited because we're now moving from a hosted organisation to two new independent organisations, one that will be looking at the big national investigations, looking at actually how we learn from things that are going wrong across the country and share that learning with all of the parts of the NHS, and then one that will be looking at maternity investigations, which are much more focused on the local investigations and the learning.
Yeah. Rosie, just going back to the origins again, you mentioned Charles Vincent, who I know has been a champion of patient and family engagement. You've had several leaders there. I mean, Jeremy Hunt, Sir Liam, who've just been, champions too. But was it, and Sinnøve mentioned stories. Was it stories? Was it research? I guess you did have more than one investigation of cover-ups in your country too. Was it a combination of all those things? Was there a particular story?
I think there was a combination of things, and certainly, one of the members of our education team is actually someone who has lived experience in terms of maternity services impacting on poor outcome, and sadly lost his baby. And I think these stories were very prominent, and I certainly did impact. And you may have heard Jeremy Hunt, who is a very much a strong advocate of ours, one of our politicians, who's now our Chancellor actually in the UK. He tells a story in his book about actually quite early on how he started to read letters from patients and really understand what is going on from a patient perspective. And I think that was very powerful in terms of how we were set up. And certainly the way our methodology has a very strong patient voice. We want to hear from patients who've experienced harm. We want to investigate their experiences, and we use. I think it's one of the things we've learned very much as we've gone along is how do we really embed that really strong patient voice through what we do, and I think we're still on a learning curve with that at the moment.
Okay, thank you very much. I do want to kind of transition now to our second question, just again in the interest of time, and that is that we're really interested in how you're structured. So what's on the bubble here in the United States is an agency that's independent from the regulator. So it would have the ability to gather data, look at everything from big data databases to reports from patients or whistleblowers or anyone, and then look for trends and then make recommendations to the different agencies that are involved. Is that similar to, and there's a real sense here that you have to keep the investigation body connected to but independent of the regulator. Is that true in your countries as well, in your systems? Rosie, you're nodding, so let's start with you.
Yeah, so I think certainly in the UK, the patient safety landscape is a complicated landscape. I think going back to Charles Vincent, he wrote a lovely paper explaining there was 126 organisations involved in patient safety and many regulators. So if you're sat in a hospital, there's a huge group of people that work around you looking at patient safety. And I think that we've got quite a lot of work still to do in the UK about how we coordinate and work together across all of those agencies. Our independence is very important to us, and making sure that we can maintain our independence of our investigation, that they are free of interference from other bodies, that we're able to have the freedom to investigate what we think is important, make recommendations that are not kind of altered by anyone or influenced by political agendas and things is very important for us. So it's very important that we maintain that independence. But I think you can be independent and collaborative. I don't think they're mutually exclusive. And I think if we are going to have the maximum impact on really changing the dial on some of these kind of really significant things that are going wrong in our health system, we need to be working with the other partners. So we make recommendations to the national bodies and sometimes to regional bodies as well. And those recommendations very much are to people like regulators, royal colleges, the national NHS England body, and health training bodies and others. So it's very important to us to work with those organisations. And I think our next step in our journey is actually to then look at what in more detail what impact that's had on what happens to people on the ground, which is, I think, further down the line.
So the thought here, and this is again based on the aviation industry that you mentioned, is that the recommendations from an independent agency will be so persuasive that those with the power to regulate, to fine, to penalize will have to listen to them because they'll just be so public.
I think that that's what we'd like it to be. I think in reality, what we need to do is work out how we make sure that our recommendations end up on a priority list of the organisations that we're working with. So I think that sometimes we can get a response back to our recommendations that the organisation will give us an answer, but we're not confident that actually they are going to put resource and put it as a priority for them to progress. And I think that's where we've got more work to do to actually really work with those national bodies to work out how we can make sure that our recommendations do end up as a priority for them to progress in what is a very, very busy landscape where I imagine it's the same in other countries where we're dealing with all of the operational pressures and the kind of impacts of COVID and workforce shortages and other pressures that managers and senior leaders are having to deal with.
Yeah. Okay, good. I'm going to move on now, but just very, very quickly before we do. So your agency will not have the power to actually make regulations, but if you find that it's not a priority for one of those stakeholders that you just mentioned, do you go then to the regulator and work with them to enforce?
So we do have the powers to make recommendations to any agency working across the health service. If we have an escalation process, so if we feel we work with those organisations and continue to work with those organisations until we get a satisfactory response to those recommendations. But we have an escalation route through to the Department of Health and Social Care, the government body, if we're not confident that that's happening.
Oh, wow. We need to learn about that escalation process because that might be something we would add to our system. Okay, Sinnøve, can you kind of jump into the same question? Are you independent? Are you part of the regulator? And if you're not part of the regulator, how do you interact with them?
Yes. So UKOM, the Norwegian Healthcare Investigation Board, is a 100% independent governmental body, and this is stated in our law actually. So, but in the governmental structure, we are organized under the Ministry of Health. So we get our finances from the health budget, but the ministry cannot instruct us. We choose for ourselves the cases that we go into, and in theory we could actually investigate the Ministry of Health. We haven't done that until now, but we do make recommendations towards the ministry. Yes, we don't have the powers well, we have the powers to make recommendations, but not to make we don't work together with the health directorate, for example, in making guidelines and that kind of stuff. So our task is to make recommendations.
And if those recommendations are made and then not followed, do you have any pathways to escalate the way Rosie was just?
We don't have the pathways that Rosie and the UK have. We work a lot with disseminating our reports and recommendations. So we spend a lot of energy and time going on conferences, meetings, and doing presentations of our reports. But the organizations, they don't answer back to us. So we give the reports, we give the recommendations, and then to the health service, and then it's kind of up to them. But what we experience that the regulators, they take them, and our recommendations in some cases get normative. So the board of supervision, when they do their supervisions, they ask, so why haven't you followed this recommendation from the Norwegian Healthcare Investigation Board? But we don't have the power.
No, got it. So that's very similar to what we're thinking about here. Let me ask you this question too. When you look at our National Transportation Safety Board, which is the thing that we're modeling this after, most of their recommendations are actually to the regulators saying, this regulation could be better. This regulation isn't working anymore. This one is topped out. This one here's a gap. Is that where you anticipate that you're going to actually be going to, is just sort of more regulations or more recommendations to the regulators, or more to the providers?
I think we tend to give more and more a recommendation to the regulators, but those recommendations, they are kind of slow it takes some time, to make new laws, so we also in our reports we try to point at tools, at existing patient safety initiatives and work to the organizations to work on meanwhile, while waiting for these overall kind of slow processes. So and I think what Rosie said is really, really important, that you can be independent but also collaborative, and to work on the good patient safety work that actually exists already. That's important when it's useful.
Yeah, wonderful. Yeah, we're hoping that that's happening too, that they'll shine a light on the things that are working, that we'd like to spread, so that other organizations can learn from the ones that are doing something innovative. Hanna, you've talked a little bit about the structure in Finland already, but would you kind of dive into this question about how you work with the regulator, or are you part of the regulator?
Yes, thanks. Well, our system sounds quite similar than in Norway, like Sinnøve told us. We have a mandate. Well, we have also Safety Investigation Act. So our work is based on a law. So we have a mandate to do safety investigation, and we have a quite long developed investigation process system, and we can apply it to the healthcare safety investigation as well. The recommendation are the main task also in our work, and I think we should together put focus to the recommendations. What we will have from the safety investigation in social and healthcare, and how the recommendations are implemented. In Finland, we have follow-up period 10 years for all recommendations, 10 years. So first follow-up point is after 3 months, when we have gave the recommendation, and then yearly we ask from the author or regulator who has gave our recommendation, what have you done, how you have implemented the recommendation. And when we prepare recommendation and when we published it, always before that we have discussions. Even we are independent, we have a discussion with the regulator or provider who is going to have our recommendation, that is the recommendation like how they can implement it, and is it like wise, and how is it possible that they can full our recommendation?
Yeah.
So, but that process starts actually before we publish the recommendation, and it ends after 10 years. And
I
now
love-
in SIAF, 70% of our recommendation is filled.
Wow. I love the idea of a 10-year sort of process of checking in every now and again. It reminds me of the WHO's Global Patient Safety Action Plan. They're going to actually follow that for 10 years to see which
Yeah,
countries
that's
are
right.
doing what. It's a
Yeah,
nice,
that's
a
right.
nice thing.
Yeah. But of
Okay.
course, we have to take it account that the environment changes and law can change, and we don't see everything to the future. So that's of course normal in development work, but we can live with that.
Actually, on
Okay,
the
thank you.
note of sort of sustainability there, one of the things that's kind of buzzing in my brain, and I see some of the chats coming in that are congruent with this, is, one of the things that we're worried about in the US is, there are so many bodies that we have to report to, and there's so many audits we have to do, and there's so many, harm scores and events that we have to report. So really it can seem a little bit overwhelming kind of in boots on the ground hospital related work to look at, what would greater national patient safety oversight be? And the sentiment is often, oh my gosh, like this is going to be another thing that we have to report to. So really my question is, how do you identify cases to investigate? And this is a very loaded question. It would probably deserve a second segment in all to itself, but specifically for today, are there, categories of harm that you're most concerned with when so many harm events happen? How do you kind of prioritize that work? Is it objective through the use of data? Is there, a committee that, rotates out every few months or years? And then kind of a second part to this is, how are we making sure that we're equitable in some of the cases that we're looking at, and some of the harm events that may be experienced by some groups are equally as considered in I guess the running of things to investigate. So I know that was a very huge question, but I'm very interested to see, and maybe Hanna, we could start with you because you just kind of talked about the sustainability aspect. What are your thoughts there?
Olivia and
Okay,
Hanna,
thank
before you jump in, we have a nice addendum from Mary Murray in the chat box too, and that is, where do you get your data? So how does your country generate data for you to use? Hanna?
Yeah, thank you. This is very hard question. If we are talking about data, about the incidents and accidents, what happens in social and healthcare, we don't have that kind of database. The data is very fragmented, and it's like agent work to find out all the cases, what are potential to investigation. But in practical, we have done a list about the cases and example cases that should be investigated, and we have made that list based plenty of discussions with the physicians, or of course research data, and of course HW or HWO information, and but discussion with the those who are working in social and healthcare, what is happening over there, what kind of things could be potential cases, what we can learn in national level. Not every never events, I think they are not suitable to independent authority to investigate. Hospitals and other clinics are doing excellent job also by themselves. We have to calculate that kind of cases where is a potential to learn in national level. So we have a list, but that list is not like locked, because there can be always something that we don't realize before the case is coming. And well, we have like I told you earlier that we have quite many authors in Finland who are steering or evaluating or working in a client and patient safety, but the data is fragmented, and we are now creating the connections and the ways that we can get the information about those most serious cases. And I think that work is not ready, and that's maybe the biggest work for me, to find and create the pathways that I can and we can have information when something happens, because there is not only, the only reason is not the fragmented data. The one reason is that maybe the hospital or social care unit don't want to say it loud that there is something wrong, and there are different reasons for that. So we need to also change the culture from the punishment to shared learning, and same goal to create to improve patient and client safety. And I think that will take quite many years.
And I really love that you just brought that up. And I think that that is a tremendous challenge for all of us around the world. And I'm interested to kind of pull on that a little bit further and say, what does that look like for, an individual patient who's been harmed, or an individual, doctor or nurse or pharmacist? Are they able to escalate a case that could be, considered for investigation on the national level?
Yes, they can.
Okay.
All righty. Sinnøve, I'm excited to hear from your perspective, the same sort of question. How are these cases identified? What does that process look like for, individuals, but also kind of for organizations?
Yes. So our cases come from we have a national reporting system. So the main part of our cases actually come from that reporting system. And and it's health personnel and leaders, they report cases, and also patients and users and next of kin can report in the national reporting system. But we also get referrals from professional communities and from patients direct to us via our website. And in addition, we pay attention to the public debate, the media, what's going on, and we talk to professional communities about potential cases. And then we have a set of criteria that we use when we decide which cases to go into. So it's, of course, serious adverse events, potential for learning, system, framework condition, those kind of aspects. And we use, I think, that's probably common, that we use these reference cases that kind of are representative for the whole healthcare system. We have, as Hanna, we have a list, a thematic list over themes or areas that we think it's important to look into. And this list is based on our knowledge that we get from our database, our knowledge of the system, and what areas, and also, of course, the areas that we don't have any cases or reports or referrals from, because as Hanna said, there's quite a lot of cases that's never reported for various reasons. So there is a kind of shadow land, and it's important to pay attention to what do we don't get any referrals or cases of. So we don't have a board. And since we don't have a board, we have established something that we call a reflection panel that we discuss these priorities with. So the reflection panel consists of, I think it's now 15 or 16 people that represent what we think is important perspectives, including patient and next of kin. And we call them our critical friends. They cannot instruct us, but we discuss cases, we reflect together, and they give us really valuable input. Yes, and we also discuss themes with patient and next of kin organizations and with the professional environment.
Sinnøve, it sounds like you have a quite multifaceted process to identify, a lot of these events that would then, escalate into investigation. So I think that's exceptional. Thank you for sharing. I'm interested if you could talk to us a little bit more about, where does AI come into play here? Do you use, information from databases like the electronic health record or death certificates? And, if so, to what extent is that integrated with AI to inform, what you're working on?
So we don't use that AI actually now. So sorry, now I have to check my Norwegian. AI for artificial intelligence.
Oh yes, I should have spelled that out. Artificial intelligence.
No, that's okay. I got it. So not in our work on selecting cases, but of course, when we start an investigation, we will go into patient journals and that kind of stuff. And when we in our very start of an investigation, we would also, of course, look into statistics, to research and other work that has been done on that area to kind of build the case, and to see if it's a good representative case to look into.
Excellent, Sinnøve. Thank you so much for sharing that information. And Rosie, I'm sure that you have some things to shed light on from your perspective. I'm excited to hear from you.
Yeah, certainly. And just going back to Hanna's point, I think we also have a long cultural journey to go to get people to kind of raise the flag when things have either gone wrong or near misses across both health and social care in England. And particularly, I think the acute trusts are getting better towards that. But when you look at primary care, community care, social care, I think there's even further to go. So I think we've got part of this is actually how do we change the culture so people do report and record things that have gone wrong. We have a referral mechanism where we accept referrals at the moment from a whole variety of sources, including patients, healthcare professionals, and organisations working across health and social care. We are starting some work at the moment just to look at how we can strengthen that with pulling in more data from other organisations such as our regulators, such as national audits and other information that actually will help to strengthen our ability to really prioritise our resources on the most important and most significant patient safety risks. And with our new legislation in April, we also have something new happening in that the Secretary of State will be able to direct us to investigate areas as well. So we're exploring what that actually will look like in practice. I think that we also want to, in the same way, I love the kind of reflection panel that Sinnøve describes, and I think we want to look at something similar in terms of how do we pull on all of the knowledge that our stakeholders have got to identify where the priority areas should be. Because I think actually if they can understand why we've chosen investigations, then when we land recommendations as well at the other end, they will understand why they've emerged and why we're investigating those parts. So I think that's something we want to do. And just in your question about inequalities, because this is something we're on a definite journey about. And as it was mentioned earlier, unless we hear from people, we don't know exactly what's gone wrong, and certain groups are very much disadvantaged by some of the processes we have in place. So we've started to do some work exploring some of the inequalities we're seeing, particularly in maternity. We know with the outcomes for Black and minority ethnic women in maternity, for example, which we're working with other partners on. We're doing some investigations at the moment into sickle cell anemia, which there's this huge inequalities in terms of care. So I think we've got more to do and really understand how we embed equality impact assessments across our whole investigation pathway and into our recommendations. And that's certainly a journey we're on, as are many others at the moment, I think.
Wow, well, thank you so much, Rosie. And I'm very excited to hear the work that you and everybody are doing. And we did have one originally scheduled last question here, but it seems as though we have a lot of questions here in the chat. So we're actually going to turn it over to our audience members here. And I want to just preface by saying that this seems as though it's going to be a testament to our desire and potential need to introduce this topic again in future conversations. So I want to preemptively say thank you to our speakers for inspiring more questions and more work on our end. But thank you so much for being here. We'll probably tap you on the shoulder in the future. I'm going to pause, and I would love for folks to unmute themselves. We will capture all the questions that were written in the chat, so they're not going anywhere. But if anybody has like a burning question, please unmute, and we would love to hear from you in the last 8 minutes here.
We don't usually have a shy group, and I know there's some great questions.
It looks like Mary had her.
Hi. Yeah, hi. I'm the one that, so I think thank you, first of all, for this discussion. It's really, you're really just very informative and inspiring. So, and we've talked a lot about culture change, but I think we also need to understand how our infrastructure is playing a role and what changes have to be concurrent within the infrastructure, and where can the current infrastructure support this work. And so that's why I asked the question about our boards of health. We have boards of health in the United States, right? In every municipality, or sometimes a county level and a state level Board of Health. And I wonder if we know yet how they get involved in these patient safety issues.
Well, Mary, let me jump in and frame a little bit too. So I was intrigued when Rosie was talking about the very complicated landscape they've got in the UK, and I think Hanna mentioned it as well. That's certainly true here because we've got this divide between what the feds can do and what the states can do. And that's why one of the things that we're hoping this NPSB will do, or National Patient Safety Board, is make recommendations to the states and the boards there, the multiple boards there, as well as the feds. I'm just wondering how that plays out in other countries. Because we have a situation here, if you have problems in one state, if you're a problem practitioner, for example, you could easily move to another state and just, start over in some ways. And we've had a hard time getting on top of that and in control of that.
And I think even shall I come in England? So we've got quite a big reorganisation of how our healthcare infrastructure is being organised at the moment, with the development of 42 integrated care systems, which are locality-based systems across health and care, with the idea that they integrate health and care across geography, and possibly some devolution from the centre, from NHS England to those. So we are going to have probably 42 different areas with quite different ways of working and different mechanisms of arranging their care. So I think one of the things we're trying to work out at the moment is how do we have maximum impact as a small organisation with those different organisations, as well as the organisations at the centre. I think we can do so much at the centre, but unless we really tap into the people who are very close to the ground, actually, I don't think we're going to have such a big impact. So that's a live discussion at the moment.
Mary, I didn't mean to take over your question, but it was such a great question. And even within the same agency in the United States, say Department of Health and Human Services, which is our big federal health agency, we find different sub-agencies competing and not talking to one another. They're competing for their budgets, they're competing for their resources, and they don't talk to one another. Are you able to get agencies to talk to one another in any of your countries?
We're getting there. There is some just, but I think there's a lot more we could do collaboratively. And I think actually that goes back to having a kind of shared vision and shared purpose about what we're trying to achieve and how we work together. I think at the moment we're very reactive, and we need to move everyone to working to a much more proactive state. We've just had another scandal, another inquiry into a scandal into maternity in the country, and I'm hoping, at the moment everyone galvanizes around those scandals, and actually we need to get to a point where everyone galvanizes long before that and starts to work together much more proactively to keep people safe.
Olivia, can I say a comment? Thank you, all of you. I mean, this has been just so informative for us in the United States. Our European experts have made more progress than we have in the United States in this area. Many of us on this webinar are patients who've experienced harm or lost loved ones. And we strongly believe that we deserve, investigations such as you are doing. And Marty brought up, and many of you brought up, the Global Patient Safety Action Plan, the WHO's plan. And one of their strategies is synergy, partnership, and solidarity. And I think that with everybody on this screen, this is the beginning of maybe a global movement, that we together push this agenda. We learn from each other and get this on the radar, not only of our countries, but other countries, because I think this is a priority. So I just wanted to say, this is the beginning of a journey I think that we're going to take together. And I just so appreciative for your wisdom and all that you're doing. I know it's probably pushing a boulder up a hill, but I applaud all that you've done.
Thank you, Sue. Olivia, we are at time, and I know some people are going to have to run to a next meeting. I think this has been great, and I'd love to, if we could do another session like this, maybe after the first of the year, just to kind of compare notes, because we have a lot happening here in the United States in the next few months. And Armando, if you could bring up our next slide, it'll just help us kind of walk through that. But after a lot of effort from patient advocates, we finally got a meeting with our US Secretary of Health and Human Services. This took a year here. And it was triggered by a letter that our group, Patients for Patient Safety US, sent to our secretary saying, why is patient safety no longer in the strategic plan of the Department of Health and Human Services? It was such a priority in earlier administrations. Has it drifted? Why is it that not there? And it took us months to get the meeting, and we suspect it might have taken, in our last communication, it might have taken us copying the members of the relevant committees of our legislature to get the attention. But in any case, the meeting is happening. We're really looking forward to it. And it's happening on November 14th. So just a couple of weeks away. And in the invitation that some of us have gotten to that meeting, Armando Nahum, who's here, is going to be a speaker at that meeting. Rosie, to your point, he's going to tell a story about the impact in his family of having infections in 3 different members of his family, 3 different states, all in the same year, 3 different hospitals. So that will be part of sort of the compelling story. But there's supposed to be some sort of a national action alliance of the big healthcare systems that are going to be launched there. So we're very curious to hear what that's going to be like. We do have this National Safety Board, Patient Safety Board legislation that is ready to go. It's been drafted through a big coalition. It's been positioned as bipartisan. As many of you may know, we have a very partisan country here, so they really worked hard to get both sponsors from both of the major parties. And that is ready to be introduced anytime we get some breathing room in our election cycle, which our elections are November 8th. So we expect it to be introduced yet this year. There's a council of our president. It's called the President's Advisory Council on Science and Technology. Sue Sheridan serves on it, on a working group, a patient safety working group that's been put together. These are huge, hugely recognized scientists who have taken an interest in patient safety because of advocacy work and have been called upon to make recommendations about what our existing agencies can do and to identify any gaps in those agencies. So Sue, I know you can't say too much about it, but I know it's on a fast track and that your group is making recommendations to get finalized or at least condensed by the end of the year. And then our biggest, this is our belief, our biggest kind of tool at the federal level is payment. Our federal government doesn't run healthcare systems, but they pay for the provider systems to deliver care to patients and families, especially seniors and people who are low income. And so they've got a lot of clout through payment, and they've got the ability to kind of drive metrics through the system, and they're working on a structural metric for patient safety that will really call upon leaders to lead and governing boards to do their job of oversight. So we think that's going to be a major opportunity for us next year, and it could be really informed by the work that you've been sharing with us from Norway, Sweden, and the UK today. So all of that is just, we'd love to talk to you again because there's going to be a lot happening here in the next few months.
Marty, can I say one thing about the PCAST? And Rosie, I know that you've spoken with Rachel at the PCAST. And what I can say publicly is that Patients for Patient Safety did put forward in public to the PCAST an entity similar to the National Patient Safety Board, built on, modeled after your organizations. So the European organization. So I can say that publicly we have put this forward as a recommendation.
Okay, super.
Yeah.
Okay, we're a minute and a half or maybe 2 minutes behind schedule, but that's not bad, Olivia. I think we did a good job.
Terrific.
Oh, I know. I think this is exceptional. I do want to highlight that we will be sending out the recordings as well as the websites to all for all of our respective speakers and their organizations, as well as putting out a little bit of promotional material around signing up for the HSIB's newsletter. So please, go ahead and sign up for that and be sure to keep track of the work that's happening on these websites and on social media. Thank you everyone so much for joining. As we alluded to, we're hoping to do more of this in the future. Stay tuned via email, and thank you all so much for being here. We'll talk to you soon.
And thanks to our participants for the great questions. I'm sorry we didn't get to all of them, but they were very thoughtful. And let's just build on these, Olivia, once we save the chat.
Agreed. Thanks, everybody.
Thank you.